working at the Tata Memorial Hospital in Mumbai. She is the chair of the Intensive Care and Critical Care Medicine Committee of the World Federation of Societies of Anesthesiologists and the immediate president of the India Society of Critical Care Medicine. She is the past president of All India Difficult Airway Association. She served on the editorial board of several journals, including Anesthesia, Canadian Journal of Anesthesia, Journal of Critical Care, and Anesthesia, Critical Care, and Pain Medicine. Sheila will be presenting a very important topics, very interesting, assessing fluid responsiveness. Where are we today? Sheila, the floor is yours.
Good afternoon. Thank you very much for that kind introduction. Again, at the outset, I'd like to thank the organizers for giving me this opportunity to be here and visit the beautiful city of Kuwait. I'm going to be speaking about assessing fluid responsiveness and describe various tests to you and what is the relevance of this today. Now, coming to one of the recent papers, and this was a meta-analysis on fluid challenge that was done by the group of Antonio Messina. And if you see the proportion of patients who are fluid responsive, even the older studies and the new ones show that only half the patients that we treat in the intensive care are actually fluid responsive. There's nothing we do more arbitrarily than give fluids. We don't give antibiotics like that. So does it really make a difference? Yes, we know if we give less fluid, we may affect the perfusion and the oxygenation. On the other hand, there is data to show that fluid boluses in the early phase of meta-analysis, and this is septic shock, and this is a retrospective study that actually showed that most of our fluid that we give is given in the first 4 days, about 24.5% of this, and a positive fluid balance in the first 4 days is associated with increased mortality. So it does make a difference how much fluid we give. Now I'd like to elicit this with a case. So this is a patient who's presented for emergency surgery. A 55-year-old male, CA colon, inferior wall MI 1 year back, febrile, elevated white cell count, distended abdomen. He's intubated with high PEEP, a high FiO2. He's received 3 liters of fluid in the emergency department. He's tachycardic, low blood pressure, the CVP is high, and lactate is 4.5. How many of you think this patient is in shock? Raise your hands. Okay, most of you do. Okay. Now, how many of you would want to give this patient more fluid? So this is not the patient who just comes to you. This is after certain resuscitation is done, 3 liters have already been given, and this patient has come to you now from the emergency department into the intensive care unit. So those who want to give this patient more fluid, please raise your hands. No, not too many people. And how many of you think you should not give fluid to this patient? Okay, few, but you got to do something, okay? Some of you are not raising your hands at all. So let's look at this a little more objectively. Are there reasons to give this patient fluid? Now, if you see this is a patient with a perforation, there's intra-abdominal sepsis, we know there's sequestration of fluid into the bowel, there's relative hypovolemia, there's persistent tachycardia, and this patient also has high lactate. So there are reasons why we should give them more fluid. And are there reasons not to give this patient more fluid? Now, if you look at the CVP and you believe in CVP, the CVP is already 14. This patient has received 3 liters of fluid in the intensive care unit, and he also has this background of the previous inferior wall MI. And this is the kind of dilemma that we're faced in with a patient who comes to the intensive care unit. It's not during initial resuscitation when the patient is just bleeding or severely dehydrated. You know you have to give fluid. You don't need to assess fluid responsiveness. It's subsequently when you have this kind of patient with complex shock that it's really a dilemma deciding whether the patient is fluid responsive or not. So determining which patient it will be fluid responsive is really a challenge in the intensive care unit. You're walking a very fine balance you're trying to maintain between not giving too much fluid and pushing the patient into pulmonary edema. And on the other hand, you do want to restore the organ perfusion and correct the hypotension. So when you ask yourself the question, should I give more fluid? What you really want to know is, will the cardiac output increase when you're fluid loading the patient? Because if the cardiac output or stroke volume or the cardiac output doesn't increase, you're not really going to produce any benefit. In fact, you might actually produce harm. So fluid responsiveness is basically a state when administration of fluid will lead to the improvement in stroke volume and hence the cardiac output. Now, I'm sure you've all seen these Frank-Starling curves. And we have not just one curve. The curves are different depending upon where the patient is and what is the physical status of the patient. So when you see on the x-axis, you give a certain amount of fluid. Now, we presume that the patient, when we give fluid, is on the steep part of the Frank-Starling curve, which means by giving a certain amount of fluid, you have a proportionate increase in the stroke volume and the patient is a fluid responder. Well, you can have the same patient after giving a lot of fluid on the flat part of the Frank-Starling curve, or you can have a patient with a weak heart, for example, you give the same amount of fluid and you may not have a proportionate increase in the stroke volume. And this is the reason why the static parameters for fluid responsiveness like CVP, POP, etc., do not help you predict fluid responsiveness, and you need to use more dynamic parameters. So when I ask myself, should I give more fluid to the patient, I ask myself 3 questions, and I need an answer yes to all these 3 questions. Is the patient in acute circulatory failure? You and I may also be fluid responsive, but we are not in acute circulatory failure. We don't have elevated lactates. We don't have low blood pressure. The second question is the patient fluid responsive? Because if he's not fluid responsive, even if he's in acute circulatory failure, there's no benefit of giving the patient fluid. And the third, more important question is there any major risk of giving fluid to this patient? Because if he's got a bad ARDS or a poor heart, even if he is fluid responsive, I would choose not to give fluid. So it's not just fluid responder and you give fluid to this patient. So how do you assess fluid responsiveness? Now, one of the ways of doing it is performing a fluid challenge, and you have this very nice modified fluid challenge that is described by Professor Vincent. And now we don't give large volumes of fluid. We give about 4 ml per kg over a shorter period of time, like about 10 minutes. And the only issue with giving a fluid bolus, it's of course the gold standard when you give a fluid challenge, is that if the patient is not a fluid responder, you're actually giving that fluid and you can't take it back. So it's really good to have a test that can help you predict fluid responsiveness so that before you give fluid, you can actually know whether this patient is a fluid responder or not. And both the last iteration of the Surviving Sepsis Campaign guidelines and the ESICM guidelines on fluid administration in acute circulatory failure suggest that you should do dynamic over static tests to predict fluid responsiveness whenever they are available. So what are these dynamic tests that we're talking about? Now, most of them are based on heart-lung interactions, and they look at respiratory variations in stroke volume and their surrogates, like pulse pressure variation, stroke volume variation, variations in the IVC diameter that we commonly use in the intensive care unit, and even some non-invasive techniques. There's a new test that I'm going to be talking about called the tidal volume challenge that was developed in our unit, end expiratory occlusion test that comes from Professor Monet's group, lung recruitment, and a new test called the PEEP test. Now, most of these tests, they depend on heart-lung interactions, but there's one test that does not depend on heart-lung interactions and can overcome most of these limitations with this test coming from the group of Professor Tabul, and this is the passive leg-raising test. So let's look at the tests that look at dynamic changes in arterial waveform, like the pulse pressure variation and stroke volume variation. And I'm sure those of you who put in arterial lines during mechanical ventilation, you would have seen these kind of changes in the arterial waveform. And as you can see, this kind of swings. And this is more accentuated in the patients who are fluid responsive. You can just eyeball the arterial trace and you know this is a fluid responder. And this is the principle that is used when to calculate the pulse pressure variation and the stroke volume variation, the maximum pulse pressure minus the minimum divided by the mean, and the same for the stroke volume. And when you use pulse pressure variation, you actually only need an arterial line. You don't even need cardiac output monitor. And you get this kind of value on the monitor with cutoff values. So if, for example, the pulse pressure variation is more than 12, then this patient is a fluid responder. Now, how reliable are these tests? And we have 3 big meta-analyses, and these are one of the most studied tests in the literature. And if you look at the area under the curves, they're more than 0.8, and it's pretty good, these tests. However, these tests do have their limitations, pulse pressure variation and stroke volume variation. And this is a very nice graphic from a paper from Professor Tabul, which shows, these tests give false positives and false negative in various situations. You're looking at arterial waveform analysis. So if you have patients with arrhythmias, obviously they won't be reliable. But the most common condition that is seen is patient ventilated with low tidal volume. Today we use low tidal volume not only in patients who are ventilated with ARDS and ALI, but also patients with trauma, with sepsis. We're much more gentler in the lung, even on the lung. And even those of you who are anesthesiologists, even in the operating room today, we use 6 ml per kg tidal volume. So you have an excellent test that works very well at 8 ml per kg, but doesn't work at tidal volume less than 8 ml per kg. So should we be throwing the baby with the bathwater? Now, in our unit, we developed a new test called the Tidal Volume Challenge, which was published in Critical Care Medicine in 2017. And what we hypothesized is that, okay, this test works very well at 8. It doesn't work at tidal volume less than 8. So why don't we transiently increase the tidal volume from 6 ml to 8 ml and then look at the pulse pressure variation or the stroke volume variation? I think I was very naive when I looked at it. It seemed very simple, but interestingly, when we did this, of course, at 6 ml, the area under the curve was very low. When we increased the tidal volume to 8 ml per kg, it was good. But what was even better than the value at 8 ml per kg was the delta. That was the difference between the pulse pressure variation at 6 ml and 8 ml per kg. That was a better predictor of fluid responsiveness. And we had similar results with the stroke volume variation. And I can show you how easy it is to do the test when you use pulse pressure variation. And I'll show this to you in a bit. And we got a cutoff values of 3.5 for pulse pressure variation and stroke volume variation. And I can show you, because with pulse pressure variation, all you need to use is an arterial line. So here you have the monitor and the ventilator, and you have the arterial line and the pulse pressure variation here. The patient is ventilated with 270 tidal volume. That is 45 is the ideal body weight, so it's 6 ml per kg. To perform the test, I need to increase the tidal volume from 6 ml per kg to 8 ml per kg. So now he's ventilated at 360. You do this just for 1 minute because we don't want to keep the tidal volume at 8 ml for too long. And you look at the pulse pressure variation. In a responder, the pulse pressure variation increases from 8. You can see it's already increased to 10. And you watch this for 1 minute, and it's come up to 13. And after 1 minute, you bring the tidal volume back to 6 ml per kg. So you can see the pulse pressure variation has increased to 15. And now I want to bring the tidal volume back from 360 to 270. So the test is just performed for 1 minute, and then we look at the difference between the pulse pressure variation at 6 and 8 ml per kg. And here we're bringing the tidal volume down. Now we started with a pulse pressure variation of 8. After performing the tidal volume challenge, the pulse pressure variation increased to 15. 15 minus 8 is 7, and this is more than the cutoff value of 3.5. Now this was so this patient is a fluid responder with a good specificity and sensitivity. Of course, this was a proof of concept study that was done in our department when we developed the test. Subsequently, this has been extensively studied in various centers across the globe, and now we have this meta-analysis from China, which has been done, and it's shown reliability not only in patients with ARDS and ERLI, but also, when your patients have low lung compliance, and even with use of PEEP, and it has, of course, we need more studies in prone position, etc. But this is a test that can be used when you don't have cardiac output monitoring. Let's come to echocardiographic variables, and we can look at SVC variability, IVC variability, also aortic root velocity, but I think the most commonly done now with point-of-care ultrasound is the IVC variability that we're commonly looking at in the intensive care unit. And we can look at transthoracic echocardiography very easily, and you can look at either the delta IVC or the IVC distensibility index, depending upon which formula you're using. The cutoff values are different. And what we're looking at the respiratory variations in the IVC diameter, not really the IVC diameter, and we can use this to predict fluid responsiveness. Now, how reliable are these tests? And this is the French multicentric trial that has looked at all the tests that assess fluid responsiveness and 540 patients. And if you see, the results are a little disappointing, because though IVC variability is something we commonly use at the bedside, we don't need lines to do this test, and it's very easy to perform. The learning curve is not very steep. If you look at the area under the curve, it's not very good. So among the tests to assess fluid responsiveness, the IVC variability is the least reliable. And if you look at this data more carefully, 2/3 of these patients were actually ventilated using low tidal volume. So the heart-lung interactions, also affect the IVC variability, unlike what people think. It's not just with PPV and SVC. And now we're coming to another test called the end expiratory occlusion test. And this comes again from the group of Professor Monet and Professor Taboul from France. And this is another smart test where you give a 15-second end expiratory hold. Okay, and this is a slide I borrowed from Professor Monet. You give an expiratory hold, and that decreases the intrathoracic pressure, and during that time, there's an increase in the venous return and the preload, and this in a patient who's a fluid responder can help distinguish the fluid responders and the non-responders with about a 5% increase in cardiac output is a patient who's a responder with a good specificity and a sensitivity. And we also have a meta-analysis, several studies that have tested this and have actually shown the cutoff value of 5%. Now 5%, of course, is a very small proportion, so you can't really use echo, because for echocardiography, increase in cardiac output, you need at least a 10% difference. So you need real-time cardiac output monitoring to appreciate a 5% increase in cardiac output, but very good specificity and sensitivity for performing this test. There are other tests that look at recruitment maneuvers. This is a study, old study from Matthew Bia, which has shown increase in, CPAP for 30 seconds. And of course, when you do a recruitment maneuver, you'll have a fall in the stroke volume or the cardiac output. And this can help you distinguish between fluid responders and non-responders. Needs to be validated and also standardized. But one real concern about this is the recruitment maneuvers can cause a significant amount of hypotension, and you have to be very careful about this. And that's probably why the reason why this has not gained much attraction. Another very good test that has come recently, another proof of concept study, is the PEEP test that has come from Professor Monet and Professor Taboul. And here what they've done, and these are in patients in ARDS, they've reduced the PEEP, okay, to up to 5 centimeters. And when you reduce the PEEP, of course, you reduce the pressure, so there will be an increase in the stroke volume or the cardiac output. And they found a cutoff of 8.6 that helped you distinguish between fluid responders or non-responders. Of course, this is a proof of concept study. It needs to be validated. Some people may also have concerns in patients with ARDS who are on high PEEP to bring down the PEEP. But it's an interesting concept, unlike recruitment maneuvers where you have to increase the tidal volume. And this is a very nice editorial that I saw recently from Michael Pinsky and Xavier Monet and Daniel De Becker. And here they've talked about using the ventilator and using these tests with heart-lung interactions. And they've described the tidal volume challenge, end expiratory occlusion test, and the PEEP test. I urge you to read this article because it's really nicely describing the three tests. So we talked about all the tests that use the heart-lung interactions, and as I mentioned, you have the passive leg raising test, which doesn't use this, use heart-lung interactions and can overcome most of the limitations with this test. And we have Professor Taboul, who's the one who's developed this test. And I like this cartoon from his paper because it describes how you can perform this very accurately. Now, it's important to perform this test effectively because you have to move the bed and not the patient, because if you cause any sympathetic stimulation, there'll be tachycardia, and then you're not sure whether the increase in the cardiac output is because of this or because there is an increase in the fluid, in the cardiac output. And you move the patient from semi-recumbent position, and you elevate the legs for not more than 30 seconds to 1 minute, and then you need real-time cardiac output monitoring, and if there's an increase in the cardiac output by more than 10%, then this patient is a fluid responder. Now, and we also have a meta-analysis from the same group, and which has found a threshold of 10% with a good area under the curve and good specificity and sensitivity. So if your cardiac output increases by more than 10%, when you perform a passive leg raising test, this patient is a fluid responder. And unlike the end expiratory occlusion test, where the increase in the cardiac output is just 5%, here it's 10%. So you can use some other tests, like many tests have been described, but the most reliable are, other than real-time cardiac output monitoring, could be using, VTI measuring cardiac output and increase more than 10% can be used, unlike with an expiratory occlusion test. And this is, again, another slide I brought it from Professor Monet. Now, if you look at all these commonly used tests to assess fluid responsiveness, these are the ones that are most well demonstrated. Okay, among these tests, I think the IVC variability is least reliable. Easy to perform are the end expiratory occlusion test, tidal volume challenge, PPV, because it's just a number on the monitor that you get. Applicable, I would say the least applicable is PPV and SVV. And most, one that's most applicable, low tidal volume, arrhythmias, whatever, is a passive leg raising. And the ones that can be used reliably without cardiac output monitoring are PPV, SVV, end expiratory occlusion, tidal volume challenge, and IVC variability. Another advantage of the IVC variability is it's not affected by arrhythmias like most of the other tests that use heart-lung interactions. Now, this is a nice study, a meta-analysis of patients ventilated using low tidal volume. And they've looked at the commonly used tests, and I was very happy to see our test having a good area under the curve. And if you see, most of the tests, commonly used tests, have a good area under the curve and good specificity and sensitivity to predict fluid responsiveness. Now, people often ask that, so what if the patient, does it have you can predict fluid responsiveness, does it have a bearing on, mortality or outcomes? And this is a nice study on septic patients from Argentina. And they looked at independent determinants of mortality according to logistic regression. And they found that, using dynamic tests for predicting fluid responsiveness, was an independent determinant according to this logistic regression. So, but are we asking the right question when we're talking about fluid responsiveness? Is it just okay to say that we are the patient? Is it the wrong question? So, it's important to know that the presence of fluid responsiveness does not mean that you have to give fluid. What's more important is there should be no major risk of giving fluid. So often people think, oh, fluid responsive, give fluid. Well, that's not. It's only one part of the question. What's more important to ask is there any major risk of giving fluid? And we know it's a vicious cycle in shock. You go on resuscitating, and you can land up in this kind of fluid accumulation syndrome, and this comes from Professor Manu Balbrain, and this affects almost every organ, and this is increased, results in increased morbidity and mortality. This is from one of our papers where we talked about how we can assess hemodynamics using, assess the volume status of the patient. And if you see the pressure volume curves here, as you move from a hypovolemic to a normovolemic patient, again, if you see the pressure volume curves, depending upon how your cardiac function is, how the permeability is, and also the intrathoracic pressure, you can actually move the curve towards the left, and you can have steep rises in other parameters like your venous status, your extravascular lung water. So you have to be very cautious. In a patient with who's a fluid responder and has an extravascular lung water index that's very high, I would not give fluid and probably go up on the vasopressors. I'll leave you with one of our recent papers, and this is the minutes bundle, where we've talked about the initial 30 minutes management of undifferentiated shock. And this was an expert opinion, and we gave this kind of, minutes stands for M to maintain, the ABCs, you infuse the fluids, use ultrasound, treat the etiology, and finally stabilize. And in the infused part, we've talked about how you should assess fluid responsiveness and when you should judiciously use vasopressors rather than just keep giving fluids to the patient. So again, coming back to the 3 points on when you should give fluids, the presence of acute circulatory failure, the patient is fluid responsive, and there's no major risk of giving fluid. When the answer is yes to all this, that's when I decide that I give more fluid. So my take-home message is that after the initial fluid assessment, of course, you don't need to assess fluid responsiveness when the patient just comes to you in shock, because more than 90% of the patients are fluid responsive. So fluid responsiveness should be assessed following this before giving more fluid to the patient, and don't just keep on and on giving or not giving fluid to these patients. And when you use fluid response, check fluid responsiveness, use dynamic tests. And these tests, there's a whole lot of tests that have been validated, and those that affect the positive pressure, when you use positive pressure ventilation, and on the see the effects on the cardiac preload using heart-lung interactions like PPV, SVV, tidal volume challenge, end expiratory occlusion test, the new PEEP test, and also the respiratory variations in the IVC and the passive leg raising test, which is an auto-fluid challenge. The presence of fluid responsiveness does not mean that we need to give fluid, and that's a really important message, because people think fluid responder, just give more fluid. And most importantly, no test is really perfect. And we need to integrate all the various dynamic indices, probably do a combination of these, and clinical assessment is very essential. And with that, I thank you very much for your attention. Happy to take questions.
Thank you very much, Professor Sheila, for such an excellent presentation. Now, as Professor Sheila, she doesn't stay at the end of the session. She's heading to the airport, so we can take 1 or 2 questions to her before she leaves the room. All right. What about the patient with cardiac tamponade or cardiac disease, and they have to take fluid? Do you still assess it by the pulse pressure variation or by an echo? And how we can sort out the need of fluid?
Right. So this kind of patient, it's a little complicated, and that's why I said you need a combination of tests, because especially when you have a patient with cardiac tamponade, then this may not be reliable. These tests may not be reliable, and you'll need to perform an echo. So it won't be reliable. These are the limitations of some of these tests. Yeah.
Okay. Thank you very much, Professor Sheila. You have a question?
If I may.
Question here.
Thank you. Congratulations for the presentation. It has been very comprehensive. I want to ask you about patients in the early phase when still the patients are not ventilated with high flow nasal cannula, for example, which is currently maybe most of the patients with pneumonia, etc., are managed during the initial phase. How you are assessing those patients, and also how you are combining, as you said at the end of the talk, fluid tolerance and your algorithms based in dynamic parameters? These 2 points, I think it's very important for
Right.
the audience.
So that's a very good question. So that's during spontaneous breathing, and spontaneous breathing is a challenge because when you're using these tests with heart-lung interactions, you're talking about patients who are intubated and ventilated and well adapted to the ventilator. So initially when the patient comes to you, you don't have any lines or catheters inside. So the echo is a very good way to assess the preload cardiac function and the afterload. Of course, during spontaneous breathing, the IVC variability is not very reliable, but it can give you some idea to give you, and of course combined with your clinical parameters, initially you can make an assessment. So that's what you can do. And what you talked about fluid tolerance, again, don't like the word fluid tolerance too much because you're not going to give fluid till the patient can tolerate it and there's organ failure. I like to use the word of risk of fluid administration. So I would give my stop giving my fluid when there's a risk of fluid administration, rather wait till the point when the patient cannot tolerate the fluid. So if, like you mentioned, it's a constant assessment of the patient. You can't just say that, okay, patient is just keep assessing fluid responsive and decide whether to give a fluids or not. So simple things you can do, like look at the x-ray, do lung ultrasound, clinically you can look at the patient, and then of course if you have advanced hemodynamic monitoring, your extravascular lung water, your pulmonary vascular permeability index, this can give you an idea that this patient is now, the lungs are getting flooded, there's more pulmonary edema fluid. So these kind of patients, then you would stop, go up on the vasopressors rather than give a fluid. So it's really a combination of all of this. And the way we would do it, in the beginning when the patient just comes in, we don't have lines, we use echo. Subsequently, we have an arterial line, patient is intubated, then we would use a tidal volume challenge, we would use PPV and tests like this, end expiratory occlusion test. When the patient starts getting weaned off and goes back again into spontaneous breathing, like pressure support, at that time, these tests are not reliable. Then we would have, use the passive leg raising test in combination because it doesn't depend on doesn't need controlled mechanical ventilation. So it's really a combination of tests and not one test that you can say, oh, this is the best one and you should only use this. Thank you very much.
Thank you, and thank you, and safe trip back. So we are moving to the next speaker, which is Professor John Fraser. He has an impressive CV. He's founder and director of the Critical Care Research Group in his institution, director of the Intensive Care Unit at St. Andrew's War Memorial Hospital, founder and chief medical officer of the Moto Cordis company, immediate past president of the Asia Pacific ELSO chapter, and he has 5 professorships in major Australian universities, 700 publications, hundreds of millions of Australian dollars in funds, but also he has a prolific personal life with 5 children. So congratulations for that. And now we are going to hear you talk about resuscitation-associated endoteliopathy and critical care. Is that the one? Or?
That's the one. That's the one. Yeah. Shukran Mafi, thank you. So sadly, it's only several hundred Australian million dollars. If it was $80 million, it'd be great. So it's fantastic to follow the last talk about fluid resuscitation and the lack of, there you go, the lack of problem of fluid. But I would suggest to you that fluid is a drug, and the right amount of drug is good, and the wrong amount of drug is not good. There seem to be some red lights flashing. Happy? Happy. Good. So I know the last speaker is leaving for an aeroplane, but I politely will disagree with some of the last talk based on the fact that we have to get the right amount of fluid, and I don't know that it's just dependent on physiological markers. Just because something can respond to more and more fluid doesn't mean it's the right number. And we know that too much of any drug can cause harm, and I would suggest to you that too much fluid can also cause harm. So if we look at the global burden of disease, and I'd like to acknowledge Nchifatso Obonyo, one of our Kenyan postdocs, for putting the slides together. If we look at the global burden of disease, obviously COVID changed things over the last couple of years, but cardiovascular disease, sepsis, and various septic indicators are major problems, as are trauma. And across all of these critical illnesses, whether it's infection, whether it's bypass from the cardiopulmonary system, or whether it is trauma, we can see an endothelial disease. I've talked earlier on yesterday about how the endothelium and the microcirculation is the biggest organ that we have. And if we look at the importance of the intact endothelium, it's absolutely necessary to get the tissue oxygenated and get the oxygen to the mitochondria, which is where it all happens. And regardless of etiology, whether it's sepsis, whether it's traumatic, whether it's hemorrhagic, there can be an endotheliopathy associated with the injury. So the key part of what we do in intensive care is optimizing organ function, which means getting the oxygen to the tissues, to the mitochondria, and maintain end organ function. But to do that, you need the microcirculation intact. And the microcirculation endothelium and the glycocalyx is a key component of it. So the problem is, and the last speaker alluded to it, we look at macrocirculatory parameters because it's easy to see blood pressure, lactate, urine output, echo, IVC volume, etc. But we also need to be able to look at the microcirculation. And we work a lot in Kenya and Uganda with our good friend Kath Maitland, and it's great for us to talk about sublingual microscopy in Brisbane, but it's not much chop over there. And the burden of sepsis and the burden of disease is bigger over there, and we should be aiming for some equity across outcomes, and this is why it's important to talk about this. So the question, I guess, is there endothelial microvascular dysfunction, and can too much resuscitation be a bad thing? And I would put it to you that it can be. So let's just go back to look at the concept that shock itself causes endotheliopathy, and they came up with a much cooler name than ours. Theirs was shock-induced. So the shock itself induces endotheliopathy. We know this is the case. This is a paper from a while ago from Ostrowski and Johansson's group, and they showed that in the acute stage with the adrenergic excess, etc., and shock, we do see the glycocalyx starting to shed. And the glycocalyx is a little bit like seaweed. It's the way I see it. So you've got the endothelium. The glycocalyx wasn't invented when I was at med school. And the glycocalyx is a little bit like seaweed, and it moves with the pulse, but it's really an endothelial policeman or policewoman. And it's keeping the balance between pro and anti-inflammation, pro and anticoagulation at balance. So a health, and also the gap junction between it. So a healthy endothelium is absolutely essential. So when the shock damages it, we can see leaky capillary syndrome, we see edema. But the problem is, it's not just the shock, it's not just the illness that can cause this endotheliopathy, but we would put it to you that resuscitation, the treatment of that shock, can also cause an endotheliopathy. And so the resuscitation that happens after the shock can worsen this, and this is a paper, a review paper that we did with Obonyo and our group, and Kath Maitland from Kenya and various others looking at this, because it doesn't really matter, it's agnostic to the shock that comes first, whether it's cardiac, septic or hemorrhagic. And I'm just going to go through some of the data that we've done. Most of these data are from our lab. So cardiogenic shock, I won't dwell too much on this, I'll be talking a lot bit more about it tomorrow, but if we look at cardiogenic shock, it's a massive problem, it's growing. Cardiac disease is the biggest killer in the world, and it's just going to go bigger and bigger. And if we look at all the things that we've been doing for the last 50 years, we really haven't changed much of an outcome since then, despite, and I'm an ECMO zealot, I guess, as the chair of ECMONet, but we haven't actually shown a benefit. But these machines do things, whether it's a balloon pump or ECMO or Impella. Why are we seeing no better improved outcome? And I would suggest to you that it's the problem in the microcirculation that we're actually getting here, that we're seeing the excess problems of fluid, inflammation, and coagulopathy. So in terms of what we started with looking at cardiogenic shock models, we looked at the heart failure and then a systematic review of preclinical models. We've heard time and time again from many studies of clinical studies with negative results, and from Australia, ANZICS produces a huge number of studies, but a lot of them are negative. And why is that? My belief is that we don't understand the mechanism properly. And as Einstein said, the true symptom of madness is doing the same thing time after time after time and expecting a different result. So rather than go another study with just IL-17 or this device, let's understand what's happening in the disease process first and then go in. And to do that in our lab, we used the preclinical model. So we looked at what was out there, we looked at the deficiencies out there, and then we created a model of cardiogenic shock in the animal lab with a left thoracotomy in a sheep. We used sheep and injected ethanol, 70% ethanol, to create shock. So this is one of our animals. This is my animal lab. Silver Heinzer, one of our international fellows coming across. We do a lot of EP monitoring on the open sheep as well, so we can actually see not just the echo, I'm looking at so we've created a standardized model, EF, between 17 and 20%, but we can also question the electrical physiological system in the lab, looking at this. And the model works really, really nicely. I think I showed an echo or two of this yesterday. So this is on the y-axis, on the x-axis there, time in hours, and the troponin release, and it's a pretty nice standardizable model that we can use to assess shock, cardiogenic shock, and the treatment for this. Again, I'll go through a fair bit of this tomorrow, so I wouldn't dwell too much on the data, but the bottom line is we've shown quite nicely we can get significant LV dysfunction, the end-systolic area, and we do a lot of strain work, and we can see the endomyocardium mapping. So on this study, we then have a nice standardizable model. We look at the support of pulsatile ECMO versus continuous VA ECMO, because VA ECMO, despite the costs, both physiological and financial, we actually haven't seen much of a benefit, and the question is, why is this? And this is some of Silver Heinzer's work from Estonia, beg your pardon, Silver Heinzer's work from Estonia, who's shown that the pulsatility in the treatment, the resuscitation with VA ECMO, with the continuous VA ECMO that we use clinically today, damages the microcirculation. So that the pulse that we understand that we're all born with seems to have a beneficial effect at the microvascular and the endothelial level. And there's a whole, so the hyalurons, one of the chemicals associated with the microcalyx is changed, and if we look at the number of vessels that are opened up by pulsatility. So the way we resuscitate, we get a great mean arterial pressure with VA ECMO, but at the microcirculation and the glycocalyx, there's an endothelial disease dysfunction that we are creating or worsening by the ECMO. Okay, so again, we'll talk more about that tomorrow. Septic shock, the resuscitation associated with sepsis, and the previous speaker was talking a lot about septic shock. So we understand sepsis is a massive problem, it's a global problem. These are some of the figures. 50 million cases a year, 1 in 5 deaths worldwide associated with sepsis. But realistically, fluid management, you know, I've been around for a while now, we talk about it time and time again at the meetings, but the question is, where did the data and fluid resuscitation start? So the actual data started in the Lancet. It was a while ago now. This is one of the first papers about fluid resuscitation, and then looking at the use of fluids in cholera. So cholera is not particularly like normal sepsis that we see. Cholera, and some of you may have seen it, is huge volume losses per rectum, and also a leaky capillary system. And this was the first treatment looking at solution IV resuscitation. And patients did get better because they were 5 and 10 litres losing per day. So this worked quite nicely. But then what happened was we assumed that cholera somehow was the rest of sepsis. And this is a paper by George Chalou and Derek Angus, etc., looking at the history of how we've got to there. And the actual 2 more recent papers that looked at fluid resuscitation and sepsis were really small papers. There was one paper with, I think, 23 patients and one paper with 90 patients. And this is what we've built this on. And then we go in this cascade of fluid is good, fluid is good. If the patient can take more fluid by their IVC or their echo or whichever parameter you want, if they can take more fluid, give more fluid, because if fluid's good, more fluid's better. And I disagree with that, and I think the data suggests that, and I'll go on to it. So these are the key pillars of septic management, and we're really just going to talk about the fluid resuscitation component here. And it's based on a number of brilliant studies by brilliant people, some of whom we work with. Mervyn Singer's heavily involved with what we're doing, looking at the endotheliopathy and looking at the fluid resuscitation in there. And all these studies have led to the World Health Organization management of sepsis, particularly in children. And one of our colleagues, Kath Maitland, many of you will have seen this paper. It was voted the top paper worldwide, not just across the New England Journal, not just across ICU, but across all journals. And again, let's forget Western medicine for a while. Kath did the best study in sepsis in Kenya and Uganda. She had thousands of patients, I think 2,600, and she resuscitated septic children to either bolus fluid or no bolus fluid. And chatting to her, her idea was, fluid is obviously good, we've been taught this, so let's look at the right volume of bolus. And this is a study that took 10 years. 10 years and the most outstandingly clean data. And what she showed, and she tells me the story of when she was in Kilifi at night getting the phone call saying, you need to stop your study. And she's saying, well, what is the right bolus? Is it 2, 6, or 10? And they said, you need to stop. And what she showed was the mortality difference was worse with fluid bolus rather than better with fluid bolus. Now, there's a lot of argument. We can talk about whether African children, whether malaria is the same thing. But the problem was it really wasn't changed, and we started working with her saying that we're changing definitions, but despite these data, we're not changing treatments. So again, we went back to mechanism. Kath comes across to Australia. I couldn't find fault in this study, but it didn't seem what I saw. I thought, well, we see patients, we give them fluid, they pink up, their lactate goes down, their urine goes back up, we feel like legends. And what she's actually shown in her study in Africa as well was that's exactly what happens. The patients pink up, their urine goes up, their lactate goes down, but their mortality also goes up, and it's a factor associated with the resuscitation. So we did a review paper, a volume resuscitation systematic review, found the differences, and then published this paper, this model, a sheep model again, looking at hyperdynamic endotoxemia, went into the lab, created a septic model, resuscitated and randomized to either fluid bolus or no fluid bolus, and this is the way we did it. It's a pretty long and tricky experiment. So we had sham and then sepsis with or without. I basically followed Kath's study in humans, so we didn't call this a preclinical trial. This is a post-clinical study. Kath did the clinical study first, then we went back to look at the mechanism. And the mechanism, looking at the non-bolus control versus the fluid bolus, and there's some strain work, I won't talk too much about it. But what we saw was this. We saw in the lab that preclinically what Kath demonstrated in 2,500 children in Africa, we could replicate in an animal model with absolute control. If we look at healthy is the sham, so there's no sepsis, then sepsis is red or green, and the no volume resuscitation is green, and the ones that got the bolus fluid, what we do on a daily basis, they're red. So if you looked at it, what was happening was they had a larger cardiac injury score the more fluid resuscitation. If you look at the tissue, and this is all scored, this is the fluid bolus where the myocardium's oozy, bulky, swollen versus non-bolus control. If you look at SDEF camera, which we can do in Brisbane, maybe not Kilifi, this is the fluid bolus resuscitation. And if you look at the microvasculature, it's really limited. You can see how the red cells, and we can track all these data, and you can see how much more sluggish they're moving. And if you take these out of pictures rather than to actual data, there's the sham in blue, there's the sepsis without resuscitation in green, and the patients, the sheep that we give the saline resuscitation, actually close off their vessels. So by giving more fluid, we actually drop out the microcirculation. And again, we published this in the Blue Journal looking at it, and the amount of resuscitation inotropes, we would always think, well, if we give fluid, they'll need less pressor, and pressors are bad, so that's a good thing, which makes sense. But if you look at it, to maintain the standard MAP of 65, the sheep that actually got the fluid resuscitation required more pressors than the sheep that didn't, possibly because we were making their microcirculation so sick, and the hyalurons and all these other proteins started coming off. And if we looked at the data from Kath's data in the FEAST study, the human study, where the no bolus is the lower line, this is hours since randomization and the probability of death. She started to see this gap happening. I'll just see if my mouse is working. No. Started to see the gap happening around about 4 hours here. Now, we didn't let our sheep die, we just titrated inotropes. But we started to see separation at roughly the same time in the animals and the humans. Now, that could just be by chance, but the separation is pretty big. So it does seem that the resuscitation associated in sepsis can also cause harm. Okay, but we use lipopolysaccharides, so now what we're going back to doing is doing it again with bacterial solutions, because it makes much more sense than giving LPS, so it's trickier. So this is the model we're now working on. We've just got it sorted thanks to Obonyi and the team. So we have a sheep, we give them live bacteria with a specific phage type that's clinically associated with sepsis in humans, create a properly sick animal, and then resuscitate. We'll publish the model, and the data is still ongoing, so it's a little bit early, but we've got 14 sheep so far with E. coli, SSC normal with fluid resuscitation, or drop the fluid resuscitation, use pressors, and with the hope that we minimise the endotheliopathy associated with resuscitation. Again, early data, we can't really draw too much from this, but what we're seeing is the more fluid you give, again, the more hyalurons, the more of these proteins that we lose that shed from the glycocalyx, and there is a difference to survival to 48 hours, but again, I wouldn't put too much on that just now. Hemorrhagic, coming to the end, Mr. Chair, hemorrhagic shock, same idea. We've got models of hemorrhagic shock with trauma, etc. And what we've shown in there too was that with hemorrhagic shock and resuscitation rapidly fluid responding to the hemorrhagic shock, we're also seeing shedding of the glycocalyceal proteins, changes to the microcirculation, and this is an area. So I think this is a fascinating area. Fluid resuscitation has become the end-all and be-all of sepsis. I think we need to question it more. I think we need to look at the data that said this is the #1 thing. And I think we need to be aware that fluid is a drug. Too much of any drug can be deleterious. And things like CVP and things like echoes, etc., do not mean that that is the right volume. The largest sepsis study was the FEAST study, and we've got a large amount of data pre-clinically, and we're going to continue to do that. And just to say thanks to the team that did a lot of the work, and that's the group. Thank you. I'm now going to have some fluid.
Our plan is to have the questions at the end. We have a Q&A session at the end, so we are going to move to the next session. We are going to introduce the next speaker.
Our next speaker is Dr. Lama Nazir. She's a board-certified pharmacotherapy specialist and fellow of the critical care medicine. She is a clinical affairs manager of residency program director and critical care clinical pharmacy specialist at King Hussein Cancer Center, Department of Pharmacology, Amman, Jordan. She's also the head of the pharmacy research and staff development, and is actively involved with various local and international societies. Her areas of interest and research include sepsis, antimicrobial therapy, critical care oncology, and the clinical and the application of artificial intelligence in healthcare. Dr. Lama will be talking about something also very important, insight on the evolving role of biomarker in sepsis.
Thank you very much, and good afternoon, everyone. So I'll move a bit, one notch away from the fluids, still within part of resuscitation and a lot of what we deal with in the ICU setting. I'll be talking about biomarkers in sepsis. We'll talk briefly about the role of biomarkers in sepsis and why we're really looking into the use of biomarkers. I'll talk briefly about some of the evidence evaluating the use of biomarkers, whether it's for the diagnosis of sepsis or even in terms of managing patients with sepsis. And then I'll touch briefly on some of the guideline recommendations in terms of when and how we should use those biomarkers. So we're all very familiar with sepsis. It's an organ dysfunction that's caused by dysregulated host response to infection. It's very common. We all deal with sepsis on a daily basis with our critically ill patients. But despite that, it has a very high mortality rate, and it's been described as high as 70% and 80%, unfortunately, among our patients, especially when you're looking at septic shock. Now, the key when it comes to managing patients with sepsis is early diagnosis and appropriate therapy. And these are the two main fundamental aspects in terms of providing the best care for patients with sepsis. Now, it's easier said than done, and I think we all would agree with that. There are a lot of challenges in terms of the early diagnosis and in terms of the early and appropriate treatment of patients with sepsis. So when it comes to the early diagnosis, a lot of the signs and symptoms that patients present with are nonspecific. We use fever, for example, which we commonly associate with infection, but we all know that fever is not always associated, is not only caused by infection. And we have a lot of patients who come in with sepsis and with infection, but they may not be febrile at the time they present. And there's a lot of other signs and symptoms that patients present with that, again, are very nonspecific, whether it's altered mental status, hypertension, tachycardia, and tachypnea. So it makes it challenging in terms of the early diagnosis of patients with sepsis. The source of infection, we think about a source of infection that may be a signal suggesting that there is sepsis and that there's a serious infection, but that's not always available, and we may not be able to identify that right away as the patient is presenting to the ICU. And there are a lot of sepsis criteria and sepsis scores that have been published and developed over the years, but even those scores have their limitations in terms of sensitivity, in terms of specificity, and also in terms of the generalizability to the patients that we deal with. Now, when it comes to the early appropriate treatment, that's another challenging part by itself. So when we start with treatment, most of the times we don't know what the pathogens are, so we try to go broad. But how broad should we go? Do we need to cover all the multi-drug resistant pathogens, or should we not? Should we cover viral? Should we not? Should we cover fungal? Should we not? So it becomes challenging in terms of deciding what's the best initial treatment for those patients. A lot of times, nowadays we have those rapid tests, so within a few hours you can get an idea of what the culture is. But there are many times where we have culture negative sepsis, so that becomes even more challenging, as how do you choose what's the best treatment for that patient. And then another, completely dynamic process is the pharmacokinetics of drugs in sepsis. So even if we choose the best drug for the best pathogen, for the best patient, is that the right dose? Do we truly understand the pharmacokinetics within those patient populations that we're dealing with? So again, it makes it kind of challenging in terms of how we manage patients with sepsis. We rely significantly on laboratory tests. So we do the blood analysis, the white BC, just kind of the traditional tests that we use. We get the blood cultures. A lot of times we use the rapid test, so that really helps in terms of identifying. But still, as I mentioned earlier, there's still a lot of challenges in terms of being able to achieve that early diagnosis and the early management of patients. And that's where biomarkers came in, is trying to offer or being a tool that can help us better diagnose and better manage our patients. This is a review paper that looked at all of the biomarkers that have been studied in sepsis. It's not very new, but they did a very good job in terms of really looking at all the biomarkers that have been studied. There were close to 180 biomarkers that were tested in sepsis. Some of them were tested in experimental studies, some that were tested in both experimental and clinical, and some that were only tested in clinical. If we look at those that were specifically for the diagnosis of sepsis, at that time there were 34 biomarkers that have been studied, but most of them had low sensitivity and specificity. But throughout the years, we've had a lot of research being done on a lot of those biomarkers. And I would say that at this point, I think the two biomarkers that are most commonly evaluated within sepsis are procalcitonin and the C-reactive protein, or CRP. Procalcitonin is a precursor for calcitonin, and in healthy individuals that have no sepsis, that are pretty healthy, the levels are undetectable. It's upregulated by the cytokines that are released during sepsis, and it's specifically with the bacterial infection that we see an increase in the procalcitonin level. It increases very rapidly, which makes it a very good biomarker in terms of being able to diagnose or identify bacterial infection. And the higher the level is, it could suggest that there is a more severe infection. The other nice thing about the procalcitonin is that it has a relatively short half-life, and so once the infection starts to improve, then that level starts to go down. So that could also be an indication that the patient is improving or responding to treatment. The C-reactive protein, on the other hand, is an acute phase protein that's secreted by the hepatocytes in response to both pathogen and tissue damage or inflammation. So it's not specific just for infections. We could also see an increase in the CPR due to tissue inflammation. But generally, the very high levels of the CRPs, they seem to be more associated with infection and also with bacterial infections. There's been so much studies over the years trying to test whether procalcitonin is better than CRP, or CRP is better, or maybe we need to combine both and look at both together and make a decision based on both of them. I won't go into the details of those because I think that's a controversy by itself, but there was one recent study that came out, and I think that kind of clarified things more in terms of procalcitonin versus CRP. And that study was specifically looking at whether CRP or procalcitonin would have an impact on decision making in patients in terms of the duration of antibiotic therapy. So it wasn't too much about the prediction or prognosis or the AUCs. It was more of whether it was the procalcitonin or the CRP that would be a better biomarker for decision making. It was a very nicely done study, a multi-center study, 41 ICUs that were included from UK centers. It included adult patients that required critical care for 24 hours and were initiated on IV antibiotics for sepsis and required at least 72 hours of treatment. And they randomized the patients to one of three groups. So it was either a group that was managed by a procalcitonin guided protocol, or another group that had the CRP guided protocol, and the third group was the standard of care. And their endpoints were very nicely done. You know, it was very clinically relevant, looking at the total duration of antibiotics. So giving those protocols, did it actually have an impact on the duration of the antibiotics? If you look at the table here, as far as the primary efficacy endpoint, it was the antibiotic treatment duration at day 28. In the procalcitonin guided group, there was a significant difference between the procalcitonin and the standard care group. But with the CRP group, there was no difference in terms of the duration of antibiotics between the CRP and between the standard of care. They also had a primary safety outcome, which was the mortality at 28 days. For the procalcitonin, it was non-inferior compared to the standard of care. For the CRP, it was inconclusive just because it was somehow higher than what was reported with the standard of care. But the general conclusion based on that was that the procalcitonin would be a better biomarker for antibiotic utilization and in terms of patient outcomes. And so again, a lot of the research, whether it's based on this study and also based on previous studies, have looked more specifically at procalcitonin to guide antibiotic treatment in patients with sepsis. So let's go back to the two challenging parts with sepsis. So again, it's the diagnosis. So is this sepsis? Do I need to start antibiotics? And in those cases, do I need to use procalcitonin? Would it help me in terms of the diagnosis and to initiate antibiotics? And then the other challenging part, which is the treatment, to guide antibiotic therapy and to optimize the duration of antibiotics that are used. There's the last guidelines from the Surviving Sepsis campaign had recommendations regarding the use of biomarkers. And their specific recommendation in terms of the procalcitonin or the biomarkers to start antibiotics is what I have here. So what they suggest is actually against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation. So in other words, if it's a patient who's suspected of having sepsis, and there's a high suspicion for sepsis in that patient, then procalcitonin is not recommended in that case, and it's recommended to just go ahead and start antibiotics. And I'll share with you an example that I commonly use to just kind of demonstrate the rationale behind that recommendation. So if we look at a case here, which is probably a case that a lot of us encounter, 67-year-old male patient transferred to the ICU due to worsening respiratory failure. Past medical history is type 2 diabetes, COPD, and hypertension. His O2 stats are 85%, blood pressure is low, heart rate is 124, patient is mechanically intubated, we start IV fluids, we give vasopressors, the white count is elevated, lactate is elevated. We probably don't know if there's no clear source of infection at that point, for example. If it's someone that was just admitted, maybe the cultures are pending for that patient, chest x-ray is still pending. But given those signs and symptoms that that patient presents with, if we ask, would you start antibiotics, most likely I will be starting antibiotics for that patient. So if I get a procalcitonin of 10, I will still be starting antibiotics. If I get a procalcitonin of 50, and we've seen 50 in patients, I will still start antibiotics. And if I get a procalcitonin of 0.1 or less, I will still be starting antibiotics. And again, that's the rationale behind saying that if you get a patient who's admitted with a suspected sepsis, the procalcitonin will not change your decision. Just go ahead and start the antibiotics. The recommendation in terms of the other part, as far as treating and trying to guide our antibiotic management, the recommendation is also kind of a conservative recommendation, saying that if it's a patient who has sepsis or septic shock, and the patient is stable, the source of infection is controlled, and you're unclear in terms of whether to stop the antibiotics or not, whether that patient is responding, then it's suggested that that procalcitonin plus the clinical evaluation could help in guiding whether you would continue or discontinue the antibiotic therapy. And I'll share some of the literature that's kind of behind some of these guidelines or these recommendations that came up. So there's a lot of randomized controlled trial that actually supported the use of procalcitonin to reduce the duration of antibiotic therapy. This is one of the major studies. It was a multi-center study, 15 hospitals, and they looked at over 1,500 critically ill patients. The procalcitonin group had a decreased duration in the antibiotic duration compared to the standard of care, and there was also decreased mortality. So it was positive outcomes based on that randomized controlled trial that had the procalcitonin guided arm. This is another major study that came out where they had over 1,000 patients, multi-center study, and it also reported a decrease in the antibiotic exposure with the use of procalcitonin. There was no difference in mortality, but again, it was positive in terms of the duration of antibiotic therapy. So that really supported the use of procalcitonin, and even with additional meta-analysis that came out after that, looking at all the studies that were published. This is a meta-analysis that looked at RCTs and the use of procalcitonin. And you can see with the first one, with the first part of this figure where it looks at the mortality, it was kind of on the border. So, maybe that's one that we can't clearly say that it improves mortality. But in terms of the antibiotic duration of therapy, it was certainly in favor of the procalcitonin, that it reduces the duration of antibiotic therapy. So it sounds like it's a clear answer until we start looking at some of the other studies, some of the other randomized controlled trials that did not show as positive results as what we've seen with the initial studies. So this is a study from, the initial one was a multi-center study conducted in Australia with close to 400 patients looking at the procalcitonin versus no procalcitonin guided treatment. There was no significant reduction in the antibiotic days and no difference in mortality. This is another multi-center study that was conducted in France, 58 patients with severe sepsis, no difference in antibiotic reduction, and there was no difference in mortality. And this is a recent study that we published, which was looking specifically at critically ill patients with cancer. And again, we randomized the patients to either procalcitonin-guided therapy or normal care or just kind of the usual care. And there was no difference in the time to antibiotic discontinuation. There was a signal of higher mortality in the patients that were in the patients that were in the procalcitonin group. It's hard to explain that. It was a relatively small sample size, but there was that signal in our patient groups. So we're seeing, studies or RCTs that are showing that it could reduce the duration of antibiotics, and others that did not. At the same time that we had our study looking at critically ill cancer patients with cancer, and that was the first randomized controlled trial looking specifically at that patient population, there was another meta-analysis that came out looking specifically at cancer patients. They went back to the studies, some of the randomized controlled studies that were published previously that had initially excluded immune-compromised patients, but they took patients who had a history of cancer. And with that meta-analysis, they actually reported a reduction in the duration of antibiotic therapy. So there we are. We're like, okay, so what do I say? Now, this is cancer, this shows benefit, this does not show benefit. But part of it is looking at the duration of antibiotic therapy, and I'll talk more about this. And this is one of the things that as we start thinking about whether the procalcitonin is something that would really benefit my setting or not, is looking at the actual average duration of antibiotic therapy that you're using in your ICU. So here we're looking at close to 10 or close to 10 days as the control group, for the control group as the average antibiotic duration. In our study, we had an average duration of antibiotic therapy that was 8 days. So maybe that could be contributing to some of the differences that we're seeing, where some settings are seeing a difference with the use of the procalcitonin and other studies are not seeing a difference. That got stuck. Okay, I moved it, that's good. Yeah. Okay, so there's certainly limitations to the procalcitonin research. There's a lot that's been done on procalcitonin. We've seen positive results, we've seen negative results, but there's certainly limitations to the procalcitonin research, which explains some of what we're seeing, so that we're kind of able to put it within perspective. There are practice differences between the centers and over time. Our practice has changed over the years in terms of how we manage our patients and in terms of the duration of antibiotics that we're using. We're certainly using much less antibiotics than we used before, and we have more antimicrobial stewardship programs that are in place. So that needs to be taken into account as we're kind of assessing the use of procalcitonin. As I mentioned, there's the antimicrobial stewardship programs, shorter duration of antibiotics. There's another important part that to always keep in mind is that there is a false positive procalcitonin that you could get with certain patient populations. We certainly see it with our cancer patients, and that's the reason we conducted our study specifically looking at cancer patients, that you may see elevated procalcitonin level that's produced by the tumor itself rather than being due to an infectious process. There's also other conditions that have reported false positive results, such as severe trauma, surgery, burns, and others. There's diversity among patients and complexity of sepsis, and I think the more we learn about our sepsis patients, we just realize that sepsis is not just one disease, and our patients are not just one patient. There's so much diversity in terms of the type of patients that we're seeing, and also the underlying comorbidities as well as the sepsis itself. The procalcitonin cutoff point, it's been generally within the same range for most of the studies, but maybe that range needs to be different depending on the patient population that we're looking at. So that's something to be taken into account. There's the non-compliance with the procalcitonin protocols. Some of those studies that have reported positive outcomes or negative outcomes may have had significant non-compliance with the procalcitonin protocols, so being up to about 50 or 60%, which is a pretty high proportion of non-compliance. And then we go, to one of the main points that I mentioned earlier in terms of the culture-negative sepsis, and that remains a struggle in terms of how do we manage culture-negative sepsis, even with the procalcitonin and some of the other biomarkers. So just to kind of summarize, the main points that we talked about, there are a lot of different biomarkers that have been studied, whether it's in the diagnosis or the management of sepsis. As I mentioned earlier, procalcitonin seems to be what has been studied the most and appears to have better performance compared to the CRP. There's certainly diversity and complexity among our patients, which make it difficult to clearly define the role of procalcitonin. According to the guidelines, the suggestion is if for initiating antibiotics, if the patient has suspected sepsis, that the procalcitonin is not recommended. But to discontinue, if you're unclear in terms of the duration of treatment, then procalcitonin would be recommended in those cases. And with that, I get to the end of my talk. Thank you very much for listening.
Thank you very much, Dr. Lama, and we'll keep the question to the end.
Our last speaker is Professor Thibault. He do not need introduction. He's an extensive investigator in the topic we are discussing this afternoon. He's emeritus professor in Paris, France, and also he's editor-in-chief of 2 important journals, Annals of Intensive Care and Journal of Intensive Medicine. So it's a pleasure for us to listen to you about diastolic arterial pressure in septic shock. Thank you, Jean-Louis.
Thank you very much, Ricard, for this very, very nice introduction. Good afternoon, everyone. First of all, I would like to thank the organizers for this very kind invitation. I'm very happy to be here to share my knowledge, my experience with you. So we talk about fluids, we talk about microcirculation or how to improve. We talk about biomarkers. We talk about the diastolic arterial pressure, which is very easy to use at the bedside. And to start my presentation, I would like to show you this example. This is a patient of 70 years old and with history of hypertension and coronary artery disease. He presents with tachycardia and clinical signs of septic shock in spite of fluid resuscitation. His MAP is 67. My question is, does this patient need a higher MAP? We could debate for hours. I will not. My opinion, because of his comorbidities, cardiovascular comorbidities, probably a higher than 67. Yes, I would say this. We can debate, but it's not the issue and the topic of my presentation. Okay, but how to do? How to increase MAP? You know that it is impossible to know from MAP alone, because a low MAP can be due to low vascular resistance, low cardiac output, or both. This is physiology. He already received fluids, so it is difficult to know from just MAP. If we give, for example, if we need to give vasopressors. And now, if I give you the values of systolic and diastolic, 92-55, and in another situation, another patient or whatever, if I give you 111/45, this is the same MAP, you can check, same MAP. I would say that the low DAP 45 in situation B suggests a low arterial tone than in situation A. And therefore, it is logical to start norepinephrine in the situation B, but not in the situation A. DAP is 55, the pulse pressure is low, could be due to a low stroke volume, could be due to a low cardiac output, and probably the treatment should not be right now norepinephrine, but maybe fluid or maybe inotropes. We have to check with echo. Just to say that MAP alone is not able to tell you anything about what to do. But it is a target anyway. So, a few words about physiology. DAP is determined positively by MAP, which is a static pressure, which depends on cardiac output, that is to say stroke volume and heart rate, and also depends on total vascular resistance. But DAP is negatively determined by pulse pressure, which depends on stroke volume and arterial stiffness. Every time you have an increase in pulse pressure, DAP decreases a little. This is what we have to know. So, if I eliminate stroke volume, DAP should depend on vascular tone, on heart rate, and on arterial stiffness. But vascular tone is definitely the probably most important determinant of DAP. We confirm this in an old study now, where we studied 84 ICU patients, and we showed that peripheral resistance was related to peripheral DAP, but not to peripheral SAP or PP, pulse pressure. So it is very easy if you look at the DAP value, because this suggests a decreased arterial tone if it is low, and it also suggests a septic origin of shock. Could be anaphylactic, but in the majority of cases, this is due to sepsis. Because we know that in sepsis, one of the hallmarks of sepsis is vasodilation due to the inflammatory cascade, etc. I will not go into detail. Just to confirm that in septic patients, before giving norepinephrine or insufficiently, in this study with Xavier Monet in our unit, we showed that it is low. DAP is low when you do not give vasopressors, 39 in this example on average. So this also suggests to administer a vasopressor, which is very simple. And when you give a vasopressor in this study, we showed an increase in the DAP. This study is interesting because it can give you an idea of the prognostic value of DAP after 3 days of resuscitation, in this study by Samir Benchekoun and Didier Payen, Alexandre Mebaza. This shows that a higher than 50 meters of mercury after 3 days was independently associated with survival, while MAP or SAP were not. Okay, after saying that, I was interested to see if in surviving sepsis campaign, GAP is mentioned. This is the last version, and I typed I use the search function of the PDF copy. I typed diastolic arterial pressure, just to know where I can find it. Ricard, no result found. Okay, maybe it is better to type diastolic blood pressure, GBP. Why not? This is what I did. No result found. It's a pity. If I go back to the past, in 2012, the paper was authored first by Phil Dellinger. If I put diastolic blood pressure, if I type this, I can find something, one mention. And if I go to this mention, it is written that vasopressors could be given early if the diastolic pressure is too low. But physiology did not change. Why this statement, this mention, was removed from the last version? I don't know. Maybe Ricard, for the next one, you could do something. You could do something, and we already reacted with Jean-Louis Vincent and others. We clearly said, more or less recently, that we should individualize initiation of vasopressors, but also that vasopressor initiation should be preferred in case of life-threatening hypotension, but also in case of low diastolic blood pressure. What is a low diastolic blood pressure? We don't know. But I went to this paper by the group of Ashish Khanna. It was a big study. Many patients were included, big registry. And they looked at the lowest diastolic blood pressure during 2 hours consecutively. And they looked at the predicted probability of ICU mortality in patients with septic shock. And they found that there is a breaking point at 44 meters of mercury. So maybe this value should be taken into account. Of course, it is a global estimation. Nevertheless, it can give you an idea of what is low. Okay, so I hope that you are convinced that low DAP provides a better reflection of low atoll tone than low MAP. But I also mentioned that DAP can be low in case of atoll stiffness or bradycardia. Atoll stiffness first. In fact, when we look at the literature, this is a big study, 500,000 of participants, so it's not nothing. This can be done in China. It was from China. And they looked at healthy participants. As you can see, so age is on the x-axis, and the mean systolic blood pressure was on the y-axis, and the mean diastolic blood pressure on the right. Systolic blood pressure increases with age. There is no doubt about this, due to atoll stiffness. But also, the mean diastolic blood pressure increases, and then, after 55, 60 years old, it decreases due to atoll stiffness. These people were not sick, they were healthy. So probably it was due to stiffness. But the value observed after 70, 75 years old was not as low as the value we observe in septic shock patients. So if you have 40 meters of mercury, it cannot be due to age only, probably due to decreased vascular tone. And in this study, for example, by Ashish Khanna, diastolic blood pressure was low, 48 for the survivors, and 40 for the non-survivors. And you cannot obtain these values in healthy people even when they are old. Bradycardia also plays a role in the interpretation of DAP. Just imagine this kind of heart rate. DAP is here. Now, if you have tachycardia, by definition, the next heartbeat occurs earlier, and therefore there is no complete decline of the diastolic part of the arterial pressure curve. And DAP should be higher in case of tachycardia. It's normal. If you go back to your patient, you will see that in tachycardic patients, DAP is higher, except if they have a decrease in arterial tone at the same time. And just an example, two patients, A and B. Now you realize that I lack patients A and patient B. Two patients, exactly the same blood pressure, 90/40, different heart rate values, 140 versus 70. The question is very simple. What do you think about the arterial tone in these two patients? Equally depressed, more depressed in A, more depressed in B, or normal in both cases? Of course, the correct answer is more depressed in A. Otherwise, with tachycardia, you should have a higher DAP, higher than normal, which is not the case. So, in the patient A, I would give norepinephrine urgently. Probably I will give also to the patient B, but not so urgently. To take into account heart rate, it was proposed to look at the diastolic shock index, which is the ratio of heart rate to DAP. And a high DSI indicates a low arterial tone. And with Gustavo Spinatascon and others, we clearly showed in this paper that diastolic shock index was a better predictor of mortality than heart rate alone and the other blood pressure-derived variables. to my knowledge, it is not yet used to identify the patients who need vasopressors, but it should be logical. I told you that low DAP is a better reflection of low arterial tone than low MAP, but do changes in DAP simply reflect changes in arterial tone. It's not so simple. It's not so simple. We need to interpret both at the same time, the changes in MAP and the changes in DAP, to better understand what is happening in terms of vascular tone. I told you this earlier. Okay. So if the increase in MAP is due to the sole increase in vascular resistance, DAP should increase to the same extent than MAP. Very simple. An example from the literature. In this study, the authors gave phenylephrine. MAP. The MAP increased from 83 to 100. It's normal. Phenylephrine is alpha-1 agonist agent. Cardiac output did not change or decreased. So the increase in MAP cannot be due to the increase in cardiac output, because there is no increase in cardiac output, and there is even a decrease in cardiac output. So it is due to vascular tone alone. And look at DAP. It increased to the same extent as MAP did. Another situation, if the MAP increase is due to both an increase in cardiac output and an increase in vascular resistance, DAP should increase less than the MAP increase, since pulse pressure increases when stroke volume increases. An illustration. This study already talked about MAP before norepinephrine, with norepinephrine. It increased 54 to 75, plus 21. DAP increased 39 to 52, plus 13 less. So when you see this, you can understand that cardiac output increased. We check this because we measure cardiac output. It also increased due to the preload effect or maybe contractility effect of norepinephrine. And of course, less than MAP, because MAP also was increased due to vascular resistance. And we check with pulse pressure, which increased. Pulse pressure increased, so DAP increases less than MAP did. It is relatively simple to play with these values. And finally, the MAP increase is due to the sole increase in cardiac output, which is not very common. DAP should increase far less than MAP if there is no change in vascular resistance, or should not change in case of associated decrease in vascular resistance. To be honest, I did not find any paper from the literature to illustrate this. Don't forget that DAP also is the upstream pressure for the left ventricular coronary perfusion. As you well know, the left myocardium is perfused by these coronary vessels. And therefore, we know that for the left ventricle, the flow is essentially diastolic. Compared to the right ventricle, it is systolo-diastolic. In other words, if you leave DAP as a too-low level, maybe you can induce some myocardial ischemia in predisposed patients. And this is interesting. I will finish in a few seconds. It comes from a registry in France of patients with coronary artery disease and chronic hypertension, not septic patients. And they looked at the risk of death according to the diastolic blood pressure. And they found that for DAP lower than between 60 and 69, and of course lower than 60, there is a higher risk of death. And also for DAP higher than 80, and of course higher than 90. So the safer range, finally, is between 70 and 80. But these patients were not septic. But we can imagine that in septic shock patients with history of coronary artery disease or maybe history of chronic hypertension, maybe we should also pay attention to this. Okay, my take-home messages. I hope that I convinced you that a low DAP gives a better reflection of low arterial tone than low MAP. So it should suggest the septic origin of shock, insight to administer a vasopressor. A persistent low DAP despite resuscitation is associated with poor outcome. Since DAP also depends on heart rate, adjusting DAP for heart rate provides a better estimation of arterial tone than DAP alone. And the diastolic shock index was demonstrated to be a better predictor of outcomes than DAP alone. And the changes in arterial tone are better assessed by considering together the change in DAP and the change in MAP. But don't leave DAP at a too low level due to the risk of myocardial ischemia in patients with coronary artery disease. Thank you very much.
Thank you, Jean-Louis. You finished just on time, just 1 second more. I invite the 3 speakers to the podium for additional questions. We are out of time because it's 5, but we want to have the opportunity to give one question each. So there is one question in the first row, please.
Thank you for this comprehensive review. Do you agree that when they tell us in the Surviving Sepsis campaign to keep a MAP above a certain range, let's say 65 or 70, that based on your last paper that you showed, that if somebody has a higher blood pressure to start with and divide them like into 65, 75, and even 80 in people who were hypertension, not talking about diastolic, but aiming at a higher MAP in septic shock for people who were hypertensive?
This is another question, another debate. I did not want to go to this debate because I had debates with many people in conferences about the optimal MAP, depending on the history of chronic hypertension or not, blah, blah, blah. My profound belief is that in patients with chronic hypertension, yes, we should target a higher level, probably higher than 75. I would say 80 around. This is my profound belief. There is a lot of literature with contradicting results, etc., etc. This is my belief as a clinician. And also because I looked at the literature, also because I had debates against very important people, so I looked carefully at the literature. So my belief is this is what it is, what I do. But again, it's difficult to prove 100%.
Any other question? Yes, please.
Hello, my question, Dr. John Fraser. We had heard many lecture about fluid resus and giving fluid. So I'm just afraid we were before like 10 years ago, maybe in the era where we give too much fluid. Now with all the conferences we're hearing about, do not give a fluid, be careful with the fluid. I'm just worried that now our shift has focused on not to give a fluid so much that we're gonna end up not resuscitating the patient very well, maybe in the middle of the night, where we do not have all this hemodynamic monitoring, where patient in the emergency room and there's a junior resident with the patient and do not have all sophistication, and then they're just afraid to give a bolus of 500. because they think they might be harming the patient because of all the shift not to give a fluid.
Okay, good question. So let's say the dose of amoxicillin is 1 gram, and you've got a really sick patient. Would you give 10 grams of amoxicillin because they were really sick? Maybe even 20 grams of amoxicillin? It is a drug, so there is a right dose. The problem is we don't know the right dose. I definitely don't know the right dose. Fluid is a key component of it. But with Kath's work and other people's work, we show that too much can cause harm. 2,500 patient studies showed with fluid. And remember, she wasn't an anti-fluid person. This was a study, beautifully set up study that she designed to see what is the right amount. And what she actually found out was fluid bolus was incorrect. What is the right answer? Again, we're doing the Stephen McDonald in Western Australia NHMRC studies, the Clover studies doing it as well. It's saying how much fluid and how early vasopressor. We were all taught vasopressors were bad and you needed a central line. You probably don't need a central line. You probably don't need a PIC. You can do low dose vasopressor and some fluid. But that word some is only 4 letters, but that's where we're stuck. How early to start resuscitation? How early in the septic patient, and beautiful talk by Professor Tabul just before. To resuscitate is some of this and some of this, but the question is, and the variability, and we've talked about, personalising healthcare and endotypes, we don't know that, and a big component of it will be biomarkers, perhaps not procalcitonin, but early things that we can assess. We heard about latent class analysis this morning with Carolyn Calfee and Danny McCauley's work as well. So fluid is important. I think as a first thing up first, it's absolutely not unreasonable. But the question is keep going. I remember giving 2 boxes of fluid when I was a resident, 2 boxes. And I remember being pretty chuffed with myself because the CVP hadn't changed. But that's not, I don't think, what we should be doing.
Yes, first I would like to say that I fully agree with Dr. Fraser. Second point, do you know why we gave a lot of fluids until recently? Why? Do you know why? Why sepsis is associated with a lot of fluids to be given? Because the tradition was to give a lot of fluids. It comes from the 70s, 80s, etc. I can tell you because in the 80s, I was already senior intensivist. And I lived this. I experienced this. The tradition was to give a lot of fluids before giving vasopressors, for example, because we used very high tidal volumes, not 6 ml per kilogram, but we used 15, 16, 17, plus PEEP. So there was, of course, by definition, hemodynamic consequences of these high tidal volumes, and the tradition was to give fluids. Second point, we use a high MAP targets, more than 75. We use 100. Believe me, normal values. And therefore, because we started by giving fluids, we gave a lot of fluids with the hope to reach this target, which was impossible, of course, because fluids does not increase resistance, but sometimes decrease resistance. So this is why we gave a lot of fluids. And after this, we reduced tidal volume, reduced the MAP target, but we did not change our strategy, except recently because large studies, etc., showed harmful effects of fluids. This is why. But normally, we should replace what is lost, and that's it. And we should start vasopressors. For example, when the DAP is low, that's it. And you will see, you will use less fluids, even with no hemodynamic monitoring settings.
Jean-Louis, can I have a question for you? Now, if you have a patient having a low mean arterial blood pressure and a low diastolic pressures, and he's septic, you don't think that we need first to start giving fluid before going to the vasopressors? Because you said that once you have a low diastolic pressure, you go to inotropes or you go to vasopressor.
I don't
Before
say
that, you don't think there is a role of...
No, I don't say that we have to give vasopressors if diastolic blood pressure is low, of course. We have to think. We have to consider giving this. But I never give vasopressors before giving fluids. Never. Because sepsis is associated with, anyway, with hypovolemia for at least 2 reasons. First, because in general, the patient did not drink a lot the hours before and the days before. Okay, so probably has some dehydration. Also fever, etc. So you need to give fluids. And to start vasopressors, I think early if the diastolic blood pressure is low.
Right.
This is what I would say.
This is the message which we need to convey, just not to go to vasopressor without giving some sort of fluid.
So just to reiterate, Kath's study and the FEAST study, they gave fluid. It was continuous, and we've done it in the sheep study too. It was continuous, but not big boluses. So everyone got some fluid, but not the 10 mils per kilogram. It's pulling it back from there. And what the microcirculation showed was giving excess fluid actually increased your vasopressor requirement because you're dropping off your microcirculation. So yes to fluid, but no to big boluses of fluid.
Except if you have fluid losses. Evidence fluid losses, of course, you have to replace.
Any other question? I want to ask Dr. Lama one question about biomarkers and sepsis, which is very interesting. You show how the studies have demonstrated that with procalcitonin you can reduce the duration of antibiotic therapy. And except in the subgroup of cancer patients, sometimes in some studies and in the meta-analysis it goes with a reduction in mortality. I want to ask you about your interpretation of these results. So 2 days less of antibiotic reduced mortality. So why those patients that receive 2 more days of antibiotics have higher mortality? Which is the damage? How you interpret this damage of excessive duration of antibiotic? Is maybe the microbiome, or you have another hypothesis?
Yeah, that's a good point, because that's one of the main points that we tried to kind of find an explanation to. The severity of illness between the 2 groups was not different, so we could not say that the patients, even though it was a randomized controlled trial, we said, well, maybe because we don't have a huge sample size, maybe there is difference in terms of the severity of illness, and that was not the case, at least based on the scores that we had. Now, there is 2 points to it. Number one, the scores that we use to determine the severity of illness within cancer patients are not don't have a very high specificity and sensitivity for the cancer patients. So maybe, a SOFA score and an Apache score looks like it's similar between the 2 groups, but deep inside there may be some differences between them. But in terms of, again, severity of illness scores, in terms of the underlying diseases, in terms of the proportion of patients that were on vasopressors between the 2 groups, it was not different. So we could not find an explanation saying that there's a higher mortality because they're more severe in that group. Now, the other point is, could it be that the procalcitonin was having people make different decisions? And most likely it was not the case, because the majority of the times where the procalcitonin was the compliance with the algorithm was bypassed, that was in cases where they felt that the patient's condition did not meet those criteria. So again, we were not strict to the point where they were forced to follow the procalcitonin, so it was left up to the clinical judgment to decide that. So again, we don't have a clear answer for that. I can't say that it's a procalcitonin algorithm that increased the mortality, and I can't say that it's a difference in terms of the severity of illnesses of the patients. It could be by chance, but it's hard to say that. But I think it's a signal, but I think the bigger signal, or the bigger part, was that it did not show a difference in terms of the decision making. And that's the part that I think is constantly being asked, is procalcitonin may be a biomarker where it's associated with bacterial infections, it's associated with prognosis, but then how much does it impact decision and how much does it impact the duration? That's the main point, and that was the main message from that study, along with a few other studies that also showed something similar.
Okay, thank you. We have exceeded the time assigned to this session, but the topic has been very interesting. You have an active participation, so thank you everyone. Thank you, the speakers.